It was the professor who did the gastroscopy and PET scan who told me that the diagnosis was pancreatic cancer.
My GP sent me for blood tests and an endoscopy, and from that on, they found out that I had cancer.
When a patient goes to the doctor with obstructive jaundice or pain, blood tests are usually undertaken which have a specific pattern. Then usually a CAT scan will be undertaken, which gives wonderful anatomical detail these days of the pancreas. And we can see tumours down to a relatively small size. Ultrasound can also be undertaken. Patients often ask, why don't I get an MRI scan? And sometimes that can be useful as well. PET scans are not generally used in pancreatic cancer.
PET scans are done for a minority of patients with pancreas cancer. In particular, it's done for patients who are being considered for a Whipple's operation, and is to make sure that there aren't unknown areas of cancer outside the pancreas.
Generally speaking, I'll have a patient referred to me from a general practitioner or from a surgeon who's presented with some discomfort, or they've become jaundiced and their GP's done some blood tests, confirmed that the patient's liver tests are abnormal, and then they'll come to see me. They may or may not have already had some imaging tests with a CT scan or an ultrasound, and they would probably be the first test that I'd organise if they haven't already had one.
Okay, so if you need us at all, you just wave your hand or shout out.
For the patient, it's very simple and straightforward. A CT scan involves them just missing their last meal. They are put on a table, they have an injection of dye into the arm, and the scans now are very quick. They only take a minute or less, and that gives us good pictures of the abdomen and in particular the pancreas, which is the area that of course we're interested in.
Because we are finding lumps in the pancreas nowadays with these fine CT scans before they're very big, we have to be sure that they are serious lumps before they're treated. And the most sophisticated way we can get this information these days is by doing an endoscopic ultrasound with a fine needle biopsy. In this procedure, an endoscope is passed down into the stomach, and this endoscope is very special because it has an ultrasound on the side of it. And that ultrasound is directed in a way that a needle can be passed into a lesion under vision. And small lesions, a few millimetres in diameter, can have a sample taken from them to establish the diagnosis.
One thing that often concerns patients when they come to see us is whether a biopsy can spread the tumour and turn something that could be removed by the surgeon into something that can't be removed. That's not the case. Often we don't get a biopsy anyway prior to surgery if the surgeon is sure that it's a tumour. But even if we do need to get a biopsy, it's usually done through a part of the bowel that would be removed at the time of surgery anyway, so it doesn't spread the tumour cells along the track where the needle goes. And there's a misconception that doing a biopsy can spread tumour cells throughout the body, and that's really not the case.
When I visited the surgeon on the 22nd of December, he said that there is a tumour in the pancreas and it's 99.9% cancerous. And he said he didn't want to do a biopsy because that just wastes time. So he said, let's make out all the paperwork now and we'll put you down for surgery as soon as possible.
For many of the patients, when they're diagnosed with cancer, it's their first real interaction with the health system. And they're trying to deal with a new diagnosis of cancer at the same time as making appointments, finding their way around hospitals and trying to understand the information. And they're usually very overwhelmed.
It was unbelievable. I didn't really think that was it was true. You know, it was believable because I was so fit and healthy and doing all the right things, and I just thought, no, it's not true. It's something you just don't want to believe, I think.
Look, in the early stages, it's usually a massive shock to people. People may not have been feeling well for quite a while, and then when there is the diagnosis, often people talk about a medical juggernaut of interventions that happen. There's a lot of emotions that go along with that, so people feel a whole huge range of things. So shock and despair and anger, disappointment, frustration, grief at not knowing what to expect. And a lot of people say it's the loss of control and the loss and the uncertainty, which are really, really difficult to cope with.
When you're just diagnosed, I know that people are in a huge amount of shock, and what I usually tell people is get the information, review your options, go for a second opinion if that's what you feel is going to give you some more information. I think what's most important is that you find out information and that you make the best decisions that you can for yourself.
Be confident in the medical treatment that you're about to receive. I had every confidence in the specialists and the surgeon and the oncologist that I've been seeing ever since I had my treatment. Talk to other people, find out from other people what you can about the outcomes from the surgery and the treatment, and have faith in yourself.